of patient in your day-to-day practice. Presented with weight loss, tiredness, and nocturia. His BMI was 23, not very high. Blood pressure was 142 over 82. Concerned about weight loss. And the fasting blood sugar was 188 and postprandial was 286 with a HbA1c of 9.4%. And normal renal function and lipids. He admits that he takes a lot of carbohydrates. So what would be the next best choice for this patient? He had a HbA1c of 9, so maybe he might need a dual agent to begin with. So there is wide array of the anti-diabetic medications now available under 12 classes are available now to treat type 2 diabetes. And all the guidelines are uniform in choosing the first one. Metformin is the first one. And the second is influenced by the multiple international and national guidelines developed by various organizations with the intention to optimize the management of type 2 diabetes. So what is the doctor's expectation on the treatment of type 2 diabetes? Whatever medication we choose should be easy to prescribe, should provide a good control, provides long-term control, no or minimal side effects. Once daily, it should be once daily for the patient to have good adherence and protects from complication, minimal or no interaction with medications of comorbid conditions. As you know, sulfonylurea is the first one to develop first oral hypoglycemic agent. It is evolved from sulfonamales, which was accidentally found to reduce blood sugar. And so in 1940s, the first generation sulfonylurea were marketed, talbutamide and cropopamide. But University Group Diabetes Project reported higher CV mortality in 1970s. So talbutamide was withdrawn. In the 1980s, second generation sulfonylureas were introduced, that is glipizide, glibenclamide, and glyclazide were introduced in 1980s. And in late 1990s and 2000, long-acting second generation glyclazide, glimepiride, and glypizides were introduced. And after that, over 2000 to 2020, we had some cardiovascular risk studies with sulfonylurea. It was advanced study, advanced arm study, Steno-2, and TOSCA-IT studies were done. So coming to glycemic efficacy of sulfonylurea, if you this is a meta-analysis, and this compared with the other newer oral hypoglycemic agents like sitagliptin, vildagliptin, DAPA, and Saxa. And if you see, glyclazide and glimepiride scored better than all the other agents. It was equal to that of metformin. This also was shown in an Indian real-world evidence study from Kalra et al. And Mohan group, where the HbA1c reduction was 1.3 to 1.5%, and the effects of fasting blood glucose was also much better. They've also found that the hypoglycemic episodes were less in patients. There was 4 in Kalra et al. Group, and Dr. Mohan's group, it was about 0.3. So this reiterated that the efficacy is good with less sulfonylurea, less hypoglycemia with sulfonylurea treatment. So Wikipedia study, is a age-old thing. We've been seeing it in almost all the presentations. What is the highlight of Wikipedia study is that it is done when using sulfonylurea as an intensification agent in patients with type 2 diabetes. So during the study itself, it showed that there was microvascular and macrovascular complication reduction, and that also carried on for about 10 years after the end of the study. So there is legacy effect as well when you control the blood sugar earlier with a stronger agent which reduces blood sugar well. So intensive glucose therapy with sulfonylurea demonstrated reduction in the risk of microvascular complication, Wikipedia study. So what does a global guideline say about sulfonylurea and type 2 diabetes patients? There are various guidelines we follow most, some of them like ADA is one of the important things which influence our practice. International Diabetes Federation, NICE guidelines, EASD and AACE guidelines are the one which we look upon for management of type 2 diabetes. What do they say? Previously, it was all glucocentric. We were, even the American Diabetes Association was pointing out to reduce the HbA1c previously. But now it is all patient-centric, and you have to consider the ASCVD or diabetic kidney disease before you choose a medication. And so sulfonylurea was pushed to the third or fourth line in ADA guidelines. They also mentioned that it can be used as a second line therapy when the ASCVD or heart failure or CKD are not present for a patient if cost is a consideration. You can use this sulfonylurea as a third line therapy in patients with ASCVD or CKD as well, following a failure of SGLT2 inhibitor or GLP-1 receptor agonist. IDF is little lenient. They were considering our population as well. So they say that sulfonylurea can be given as a second line therapy in patients except glibenclamide and when metformin is not tolerated or a combination with metformin. So they also say that newer sulfonylureas are safe in elderly patients and so consider glycoside or glimepiride in patients instead of glibenclamide. From the NICE guidelines, it was updated in 2022, which shows says that it is in line with the ADA guidelines, where it says that you have to stratify the risk of a patient before you give a medication. And they say SGLT2 inhibitor or GLP-1 receptor agonist as a second line with metformin. But you can consider SUs in a special populations and in patients who are not tolerating metformin, or if they are having higher blood sugar, even with SGLT2 inhibitor and metformin. So you can use it as a third line. So EASD and AACE also reiterates what the ADA says, and they say that sulfonylurea should be treated as should be given as a third line or fourth line therapy, considering the risk of a patient. What do the national guidelines say about sulfonylurea and type 2 diabetes management? There are lots of countries have got their own guidelines in managing type 2 diabetes. And I'm going to highlight only about what we do in India. That is, ESI and RSSDI have formulated the clinical practice recommendations where the sulfonylurea can be given as a second line agent to be used in persons with type 2 diabetes who are not obese. So that is a phenotype of our population, and it is not that we are very obese that we develop diabetes. So sulfonylurea are preferred in South Asian population, and dose of sulfonylurea should be reduced when the prandial insulin is introduced. Glimepiride and glycoside modified release are preferred sulfonylurea than glibenclamide, which causes which is longer acting and causes more hypoglycemic episodes. So second generation sulfonylurea are recommended in diabetic kidney disease, but they also recommend self-monitoring of blood glucose of patients who are on sulfonylurea. In NICE guidelines, what they say is you need not ask the patient to monitor the blood sugar when they are on oral agents alone, and you ask them to monitor the blood sugar if the patient goes on insulin. But our population, when even sulfonylurea is given, there is a higher risk of hypoglycemia, and so monitoring of blood sugar is important, and we have to reiterate for most of the patients who are affordable and can do it. So summarizing the guideline recommendation, there are about 33 recommended guidelines which recommend sulfonylurea as a second line therapy for diabetes management, but there are not that much for the other agents to be given as second line therapy. And the International Task Force recommendation on the use of second generation sulfonylurea also reiterates whatever point which I've mentioned in the ADA and other guidelines, for use in patients who are having metformin monotherapy failure. You can use second-line sulfonylurea. It can be used as it can be used with other classes of anti-hypoglycemic agents as well. And second generation sulfonylurea is preferable than other sulfonylureas. So what is the cardiovascular safety of sulfonylureas? A review of guidelines. The advanced trial was the first one which was using glycoside modified release, and it showed combined microvascular and macrovascular complication reduction of about 10% in patients who were intensively treated with sulfonylurea. And the Carolina trial, which compared linagliptin with glimepiride, also showed that it is non-inferior to glimepiride is non-inferior to linagliptin in reducing the cardiovascular risk in patients who are older, younger. The patients were from 40 years to 75 years, and there were no increased risk in various age groups of type 2 diabetes patients. So the relative effects of linagliptin versus glimepiride therapy on CV outcomes were similar across age groups. The incidence increased and the mortality events increased with the increasing age anyway. But the HbA1c reduction was a little bit better in patients who were treated with glimepiride at the beginning of the study. But eventually, at the end of the study, there was not much difference between the HbA1c reduction between each group. But the hypoglycemia risk was little higher with sulfonylurea rather than linagliptin. If you look at the subgroup analysis again of Asian patients in Carolina group, there were about 933 patients who were Asians who were randomized to have linagliptin or glimepiride and followed up for 6.2 years. And this subgroup analysis reiterates the safety of glimepiride over, and it is equal to that of linagliptin in the CV safety in Asian type 2 diabetes patients. So this finding of CV safety of glimepiride in Asians is important because we were using sulfonylurea more than any of the other countries in the world. So findings from the Carolina trial have been integrated into most recent guideline updates, which acknowledge similar CV safety of glimepiride to DPP-4 inhibitor. So indirect comparison of Carolina and Carmelina also shows that glimepiride is non-inferior to placebo in the CV as far as CV risk is concerned, and confirmation of CV safety of glimepiride is reassuring. So TOSCA-IT trial, in this long-term pragmatic trial, incidence of cardiovascular events was similar with sulfonylurea. In this study, they used mostly glimepiride and glycoside, but also glibenclamide was also used in this study. So, and it was compared with pioglitazone as an add-on treatment to metformin. Both is widely available and affordable treatment or suitable options, and respect to efficacy and adverse events, it was all equal. And pioglitazone was associated with fewer hypoglycemic events comparing to sulfonylurea. If you take the other special population like elderly people, glycoside seem to be scoring better than glibenclamide, as I pointed out before with the guidelines. It has less hypoglycemic events comparing to glibenclamide. And during Ramadan, when you are fasting, the sulfonylurea was compared with DPP-4 inhibitors and glibenclamide. So if you see, glycoside produce less hypoglycemic events than sitagliptin itself. So it is safe to use in Ramadan as well. So as long as other special population is concerned, you have not enough data with pregnancy. So we cannot use in pregnancy, even though we have some data with glibenclamide in pregnancy. it would not be advising that at all for patients here. So in children, it is not recommended can be used, second generation sulfonylurea can be used in comorbid conditions because of ASCVD risk reduction in patients who are using glycoside and glimepiride. Sulfonylureas like glypeside preferred with people with moderate to severe CKD, and lowering the dose of sulfonylurea is mandatory in patients who are having mild to moderate hepatic impairment. So even though we have evidence of efficacy and also safety of sulfonylureas, there is difference in positioning of sulfonylurea. EASD and ADA, says that sulfonylurea should be as a last choice in people with ASCVD and CKD and heart failure. And Canadian guidelines also were similar, not advising sulfonylurea as a first-line therapy. But recommendations from RSSDI recommends glycoside MR and glycoside glimepiride as they cause less adverse events. The other guidelines like South Asian Federation, Canadian, Australian guidelines, and South African guidelines all mention about second generation sulfonylurea and glycoside, maybe because of a lower risk of CV risk, lesser hypoglycemic episodes, weight neutrality, microvascular benefits, and lower cost. So what should we do as far as Indian population is concerned? So we have to have a patient-centric approach to sulfonylurea therapy. We need to see what is the risk of patient, the comorbidities, ASCVD risk, heart failure risk, and CKD risk, hypoglycemia, the risk of hypoglycemia for the patient, the side effect profile, body weight. Our phenotype is different than other population. Cost is another important factor we need to look at, and patient preference as well. So need for individualized type 2 diabetes treatment in South Asia is mandatory. We need to have a separate guidelines for us considering our phenotype, which is diverse and heterogeneous lifestyle. We have a heterogeneous lifestyle. Environmental, cultural, and social economic factors have to be considered as well. So coming to that patient, considering his socio-economic status, he was started on metformin plus glycoside MR, 60 milligram once daily. After 3 months, fasting blood glucose was 136, postprandial was 178, HbA1c of 7.2%. He was experiencing some hypoglycemic symptoms, so his glycoside dose was reduced to 30 milligram once daily. See, he missed his follow-up. He came back after 1 year, was taking the same medication, no hypoglycemic symptoms, and his fasting was 122, postprandial of 168 with a HbA1c of 6.8%. He was asked to continue on the same medication. So coming to a summary, sulfonylurea continued to play an important role in the management of type 2 diabetes in our country. We have to choose an agent which is cheaper and which is have longer duration of durability, less hypoglycemia, and also cardiovascular safety should be considered. So I always tell this in meetings about this Tirukural, which is Utran alavum pini alavum kalamum katran karidi cheyal, which means that you have to, which is patient-centric approach, which was written about 2000 years back. Old but still gold is an apt phrase for sulfonylurea therapy in our country, at least for now. Thank you.
Thank you, sir. That was very excellently put in a nutshell. Especially, I think 10, 15 years before this, I think we never ever thought about any other drugs other than sulfonylurea and metformin in the management of diabetes. But the current scenario has changed, and there are so many new kids on the block which has replaced the role of sulfonylureas, which are trying to question the role and position of sulfonylureas in the management of diabetes. But I think sir has very elegantly put 3 things. In a country where cost effectiveness is very important, and glycemic efficacy is still unsurpassed. Sulfonylurea still holds its place, and we are moving more and more towards personalized medicine. I think sulfonylurea should be chosen cautiously in patients who actually require that medication. And again, the newer generation sulfonylureas, glycoside, glamiprid, and glyphosate, I think they are relatively safer, as time and again shown by the Carolina trial. And hence, sulfonylurea, though old, it's almost completed 75 years in diabetic therapeutics, but still it holds its place. Thank you, sir.
Now we understand that the advent of modern sulfonylureas, they still have a role, especially in the developing population like ours. One thing I want to tell us again, strict adherence of lifestyle modification is also equally important, and we have to target on all the aspects of diabetes, including the complications. And like sir, I would also like to point out one Tirukural, Marundana Vendavam Yakaikku Arundiyatrathu Potrivunam, highlighting the effect of nutrition therapy. So, any questions from the forum? We'll take up at the end of the sessions, both the sessions. Thank you, sir.
So for the next topic about CGMS, Continuous Glucose Monitoring System, I'd like to invite Dr. Shanmugasundar sir, who is a very known endocrinologist, renowned for his speech from Magna Center for Obesity, Diabetes and Endocrinology, Chennai. Over to you, sir.
Good afternoon, everyone. At the outset, I thank the organizing team of the Stendo 2022 for giving me this opportunity. So, the topic given to me is the role of CGMS, advantages and pitfall in clinical care. So, what I'm going to do in next 15 to 20 minutes is basically what should we know about CGM. So, what are the types of CGM available in our country, and what are the important concepts? What should we look for when the patient comes to us with the CGM report? What should we look for? And what is AGP, ambulatory glucose profile, and how to review this in a nutshell. And then I will discuss about the advantage. What are the studies available to say that this time in range and CGMS is beneficial for the patient, and in what ways? And what are the barriers or the disadvantages of using the CGMS? And what are the patients requires CGMS in our clinical practice? So what is continuous glucose monitoring? Basically, a sensor measures the glucose level in the interstitial fluid, whereas blood glucose measures the glucose in the blood. So CGMS has a sensor, it has a transmitter, and usually the phone or we will have a receiver which receives the data from the sensor. And there are two types, real time and flash. So real time means the transmitter will be continuously sending the data to the receiver, that is either the handheld receiver is there, or phones nowadays, a lot of apps are there with which we can receive the data. So it's a real time glucose monitoring. Second is flash glucose monitoring. Here the patient periodically has to scan the sensor. So the receiver then takes the data from the sensor. So at presently available the Sabot Libre, you have to take the data every 8 hours. The sensor has the capacity to store the data for 8 hours. If you are not going to scan within 8 hours, the data will be lost. So the flash glucose monitoring, patient has to scan the sensor frequently. So HbA1c is a time-tested measurement. We know that it measures a long-term glucose control in the last 3 months, and lot of data are there with HbA1c, which are shown by keeping the HbA1c within the control leads to good reduction in the micro and macrovascular complication. But the HbA1c does not reflect daily glycemic excursions, and does not tell us whether the patient had any minor hypoglycemic episodes in the last 2 or 3 months. So we don't get those data. We'll just get a number. So the same number can be achieved in a 2 different ways. The patient may achieve it without any glycemic variability. The other patient would have been had multiple episodes of hyper and hypoglycemia, but with the same HbA1c. So we don't have any of those data with the HbA1c, and we don't know exactly how much postprandial glycemic excursions has happened with the HbA1c level. Whereas CGMS addresses all this lacuna. So we know what are the daily glycemic excursions happened in the patients in the short term, last 7 to 14 days, and how many hypoglycemic episodes have happened with the patients. And we know with respect to the patient lifestyle or the food pattern or the medication, how the postprandial glycemic excursion has been happened, and how much time the patient is within the time in range. So that concept time in range is a new concept, new glucose metric. So we will know from the CGMS how much percentage of the time the patient is within the range, above the range and below the range. And another important thing is patient trend towards the hypoglycemia and hyperglycemia. So these are the many concepts I will be discussing in the future slide. So what are the types of CGM systems? One is the professional CGM and personal, and another is personal CGM. Professional CGM is the owners, the clinic, the doctor or the hospital will own the receiver. So the patient will be put in sensor, and the patient will come back come to us after 7 days or 14 days, and we take the retrospective data. That is the professional CGM. 2 to 3 years before we were using this professional CGM. So examples are iPro 2 by Medtronic and Freestyle Libro Pro. But now we have this personal CGM. That is, the patient owns the receiver. So it can be a company given receiver, or it can be a mobile phone also. So here we will get the real-time feedback. In the real-time CGMS, automatically the sensor will be sending the data to the receiver. If it's a flash device, the patient has to scan frequently so that the sensor will give the data to the receiver. And it can be wear for 14 days also. Now we have this Freestyle Libre, the patient can wear it for 14 days. So we can real time, we can see the data. And personal CGM is not compatible with the insulin pump, and professional CGM. Personal CGM, it is compatible with smartphones, and also it can be linked with the insulin pump so that this loop can be formed. Automatically the insulin pump can deliver the bolus insulin. So comparison of personal CGM systems. So there are 4 types of personal CGM system: Dexcom's G6, Freestyle Libre Flash, Guardian Connect, and Eversense. In India, mostly we use Freestyle Libre and the Guardian Connect. So I'll just focus on these 2 things. So the main difference is the calibrations are not required in Freestyle Libre, whereas calibrations are required in Guardian Connect. MARD, that is which tells about the accuracy of the CGM. So it's 9.4% in the Freestyle Libre, and Guardian Connect is 9.54. And insulin pump integration can be done with the real time. Now even the Freestyle Libre Flash, now the real time has come in the Western countries. It is called Freestyle Libre 2. It's not available in India. And FDA approved for dosing, again very important. It is approved for Freestyle Libre. That is, if the patient has hypoglycemia or hyperglycemia in CGM monitoring, the dosing, the insulin dose adjustment can be done if the patient is wearing Freestyle Libre, whereas in Guardian Connect, the patient has to confirm with the glucometer reading. And for pregnancy, Freestyle Libre is approved. Guardian Connect, still we don't have the approval. So coming to important concepts. So I will discuss about lag time and what is the trend. Trend means what in CGMS, accuracy of the CGMS, time in range, and other important concepts. So lag time, very important slide. So this green indicates the plasma glucose level and the red indicates the sensor glucose. So if the patient is experiencing hypoglycemia, if we see, there is almost 5 minutes lag time between the sensor value and the patient, this blood glucose value. So usually the sensor glucose value lag behind the plasma glucose. So always, if the patient has hypoglycemia, it's always better to confirm by the blood glucose. And the second thing is, when we give treatment for this hypoglycemia, again, if the blood glucose rises, the sensor value lags behind the blood glucose lags behind the sensor value by almost 5 to 10 minutes. Why it is important is, the sensor value is showing very low sugar glucose again and again, we will be giving treatment again and again. So the patient can land up in significant hyperglycemia. Again, when you are going to treat the patient hypoglycemia, when the sensor is showing hypoglycemia, low glucose values, always better to cross check by the glucometer values. And when the patient has been treated, if you see again, the sensor value is lagging behind the blood glucose value, glucometer value, sensor glucose is lagging behind the blood glucose, and usually it overshoots after some times. So this lag behind the blood glucose value, you should know. When the patient is experiencing hypoglycemia and when you are treating hypoglycemia, it's always better to reconfirm by the glucometer value rather than just taking decision based on the sensor values. What are the trend arrows? So nowadays in the real-time monitoring, we will get this trend arrows. If the trend arrow is upward, it shows that glucose values are rising rapidly. So you can increase the correctional dose by 20%. And if the arrow is like this, it shows it's rising but not rapidly. So you can increase the bolus dose by 10%. If arrow is it's flat, then the glucose changing is values are changing very slowly, so no need to change the bolus dose. Similarly, for the downward arrow, if it's straight down, the blood glucose is falling very rapidly, then you have to decrease by 20%. And if this arrow is like this, then it's falling but not rapidly, so decrease the value by 10%. Again, these are the general guidelines, but individual adjustment has to be it has been taken based on the patient's comorbidities, specific needs, age, etc. So, but we should know what is this arrow indicates, so accordingly treatment has to be given. Coming to accuracy, that is measured by MARD, that is mean absolute relative difference. It helps in assessing the accuracy of the CGM. It is the mean difference between the interstitial glucose and reference blood glucose radius. So if MARD less than 10% means it's accurate enough to take the treatment decisions. For example, like Dexcom and Freestyle Libre has MARD less than 10. So that's why FDA has given approval to make decision based on the sensor values. If MARD is more than 10% means it's always better to check the glucometer reading, crash check by glucometer reading before making the decision. And we have to remember the accuracy of sensor is dependent on the blood glucose range within the range. If the patient is having significant hypo or hyperglycemia, it's always better to crash check. Also, it showed the lag time between the difference between the sensor and the blood glucose value. So if there is any significant hypo or hyperglycemia, always crash check with the glucometer values. Coming to time in range, new glucometric for managing diabetes. So it tells us how much duration the patient is within the range, 70 to 180 milligram per deciliter, and it also tells us how much time the patient is below or above the range. So the recommended TIR, time in ranges, range targets are for the different diabetic population is different. So type 1 and type 2 diabetes, older patients, and pregnancy with the type 1 diabetes patient, pregnancy with the type 2 diabetes, and gestational diabetes, it's all different. So I will concentrate on type 1 and type 2 patients. So the time in range is the value of 70 to 180 milligram per deciliter. At least 70% of the time, the patient should be within the time in range. And time below range, level 1, that is from 70 to less than 70 to 54, the patient should be in the less than 4%. Time below range, level 2, it should be less than 1%. That is time below range, level 2 is less than 54 milligram per deciliter. Time above range, level 1, less than 25% of the time, the patient should have 180 to 249. And time above range, less than level 2, that is, it should be less than 5%. That is, the patient should have more than 250, less than for only 5% of the time. So this is for the type 1 and type 2 non-pregnant patients. For GDM and type 1 high-risk patients, it's completely different. Other consideration, the paracetamol intake again interferes with the interstitial glucose measurement, particularly with respect to the older Dexcom and Medtronic. Newer Dexcom and Medtronic has addressed this issue. And direct pressure, any direct pressures on the CGM again interfere with the local blood flow, so that again can lead to alteration in the value. It shows low value, so that should be taken into account. Coming to ambulatory glucose profile, what is ambulatory glucose profile? So this is how we will get the report in the ambulatory glucose profile. So time in range already discussed. So glucose management indicator, before it used to be mentioned as estimated HbA1c, now it has been changed to glucose management indicator. So that tells us average, approximately average HbA1c in the last 14 days. Second is glucose variability. So how much glycemic variability is happening in those last 14 days. So usually it should be less than 33%. So we also get daily glucose profile like this, and ambulatory glucose profile retrospective data, average of the last 14 days. So here lot of data we can see, get it from this. So this center dark line indicates the median blood glucose. So it tells us the average blood glucose at point of time. For example, at around 10 p.m., the average blood glucose of this patient is around 250 milligram per deciliter, 10 a.m. And this dark blue indicates 25th to 75th percentile. So this is the time, most of the time the patient is having a blood glucose between this 25th to 75th percentiles. Third, this light blue indicates 10th to 90th percentile of the time. So when this data are present, what should we see? First thing what I will see is how much time the patient is experiencing hypoglycemia. For example, I don't want my patient at any point of time less than 54 milligram per deciliter. That is, the 19th centile at any point, it should not be less than the 54 milligram per deciliter. Then I am more concerned about this patient. Second thing is, if 25th centile, if it is less than 70 milligram per deciliter at any point of time, again I am concerned that my patient is prone for hypoglycemia. So this first I will notice this 10th centile and 25th centile. So 10th centile any point of time less than 54 or 25th any point of time less than 70, then we should address that first. Then if those things are not there, if my patient is not having hypoglycemic episode, then I am more happy to see the center line, median. So what at that particular time, what is the average blood glucose? So when the hyperglycemia is happening and what could be the cause for that? Again, you can address. So in this patient, if we see the patient is developing hypoglycemia, so we have to address this. And also post meals, post breakfast and post dinner, he is having hyperglycemia. So we need to ask the questions, what type of meals he is taking, whether the insulin dose is appropriate, or there is any change in the exercise pattern day to day. So all those things has to be questioned and has to be addressed. So how to effectively review this AGP data, because a lot of data we have. So first thing is mark directly few things, type of diabetes, duration, age, and what time he goes for walking, what time he used to take the meals, what type of meals he is taking, how much carbohydrate he is taking, and what are the medication he is taking. So all those things, mark those on the AGP. And next is look for the patterns of low glucose reading. Already discussed the 10th centile less than 54 or 25th centile less than 70 milligram. You need to address that first and look for the patterns of high blood glucose value. That is, if the hyperglycemia is happening at a particular time, again ask for the meal pattern, exercise pattern, all those things, and try to address that. And finally, go for the action plan. So change in the lifestyle, change in the diet, change in the insulin dose, all those things can be discussed with the patient with this lot of data. So how to approach? So after getting all this data, we can change the meals. So after changing the meals, we can see how much the blood glucose is coming down with the lifestyle modification itself. So the patient can scan hourly for the first 4 hours post meal, so that he can get the data. So accordingly, he can change the diet and see whether the blood glucose is coming down. And before and after exercise, it's always better to monitor the blood glucose. So during immediately and after the exercise, whether there is any significant change in the blood glucose. And during illness, again, it's a good tool to see whether the patient is experiencing any hypo or hyperglycemia. And post insulin dose correction, or say the patient is taking OH also, post changing the doses, any hyper or hypoglycemia is happening, or whether the blood glucose is within the range, we can get data from this. Coming to what are the benefits of CGM. So time in range. So if you see this time in range, if there is a 10% decrease in the time in range, there is a 64% increase in the retinopathy and 40% increase in the nephropathy rate when the time in range is decreasing. So again, this is a exploratory data from the DCCT study. And coming to macrovascular event, 10% increase in the time in range leads to 6.4% lower risk of abnormal carotid intima media thickness. And this is data in the peripheral neuropathy in type 2 diabetes and CKD. Again, with increase in the time in range, the neuropathy prevalence is also decreasing. And this is the data on the autonomic neuropathy. And the autonomic neuropathy is significantly associated with the change in the time in range. Good thing is the autonomic neuropathy decreases with the increase of TIR. So there is, if the TIR is improving, the autonomic neuropathy is also improving. So this data says the autonomic neuropathy is more if the TIR is less, and if TIR is improving, the autonomic neuropathy prevalence is also decreased. This is the data based on TIR. So there are few landmark trials for CGM. So I'll discuss only important landmark trials. So Diamond and this Gold trial, it has been done in type 1 diabetes with poorly controlled type 1 diabetes. So they have shown there is improvement in the HbA1c level, but we don't want this one only, because the main use of CGM is to decrease the incidence of hypoglycemia also. So the IMPACT trial is again a very well conducted trial. They have chosen well controlled type 1 diabetes, and they have seen there is a reduced time in hypoglycemia, because in type 1 diabetes we are more worried about hypoglycemia. Usually the patient goes for the hypoglycemia due to glycemic variability. So this data shows there is significant decrease in the hypoglycemia. And replace study has been done in type 2. Again, lot of CGMS data are with type 1 diabetes. Type 2 diabetes, we have very, very scarce data. And here, type 2 diabetes on insulin therapy, they have done this study. They have shown there is a sustained reduction in the hypoglycemia. and episodes in the type 2 diabetes patient also. Concept studies done in pregnant patients, they have shown more time in targets, less time hyperglycemia, and neonatal outcomes also significantly improved with the CGM. Cosmer study again in type 1 data, there is a significant decrease in HbA1c and hypoglycemia with SIR, sensor augmented insulin regimen. FLAR data from both type 1 and type 2 from Netherlands, they have showed 58% reduction in the work absenteeism, and they are also improved in the quality of life. Coming to barriers, what are the important disadvantages of using CGM? One is the cost, and in our country, insurance doesn't cover the CGM. Aversion to wearing a device on the body, and many times you do see patient after second or third day they used to remove the CGM, and they don't want to show to the other that they are having diabetes. Denial of disease. Over much data, we are talking about data, we are getting a lot of data from the CGM that helps in the patient. Sometimes over data also can lead to diabetic distress, and many times if the patient gets frequent alarm, that also can cause alarm fatigue. Sensors, side skin irritation or aggressive problems, we do see some of the patient. Data gap, sometimes if they are not going to scan the flash glucometer, flash CGM, every 8 hours the data can be lost. Body image concerns in the young. Clinician or physician barrier, if they are not very well versed with the CGM, they don't know how to download, how to install, again, the physician may not advise the CGM to the patient. Coming to the last part, there are Indian guidelines, consensus guideline on CGM. So these are the recommendations for the CGM. So in type 1 diabetes, adult and pediatric, whenever the patient is having severe hypoglycemia or hypoglycemic unawareness or uncontrolled hyperglycemia, then CGM is recommended. Type 2 diabetes, receiving insulin sulfonylureas, again it's strongly recommended, particularly if the patient is prone for hypoglycemia. Gestational diabetes, the CGM can be used to evaluate the glucose pattern, fine-tune the insulin regimen. Again, the concept study has shown there is a significant improvement in the neonatal outcomes also with the usage of CGM. So to summarize, CGM is a promising technology for improving glycemic control. Not only improving glycemic control, there is a significant decrease in the hypoglycemic episodes also. Most of the data are with the type 1 diabetes. We have few data to support for use in type 2 diabetes also. And it also helps in managing the patient-specific PPG excursions. And novel parameters, it's helpful for managing the diabetes in a better way, like time in range, glycemic variability, AGPs, and trend. What are the changes in the glucose trend values help in making the decisions. And overcoming barrier is very, very important, and a lot of patient barriers is there, particularly the cost, and they don't want something to be attached to the bodies, many times. So counseling is very, very important. And clinical barriers by good education to the physicians, like having the hands-on experience with the CGM and how to interpret the data. If the physicians are taught, they may use this technology more in the coming days. Thank you. Thanks for patiently listening.